This is the Fix Your Sciatica podcast. In today's world, there's an endless amount of possibilities and treatment methods to managing pain, whether it be back pain, sciatica, anything related to the spine, and it can be extremely overwhelming. And I know a lot of people would rather not go underneath the knife and get surgery, but there are some cases where surgery is exactly what is needed, and then we can go back into living our lives. And so I myself, as a physical therapist, I know of these procedures, but I'm not the one doing those procedures. And today's guest was very kind enough to share his time with us, and he is the leading forefront in some really amazing minimal invasive surgeries for the spine. So today I have Dr. Abbasi, and we're going to go right into it, talk about spinal surgeries, what he does, and how these surgeries can in fact help people such as yourself. Dr. Abbasi, thank you so much for being on today's episode.
Well, thank you so much for having me. I'm really happy to be here.
And the pleasure is all mine. I think there's a lot of misconceptions when it comes to surgeons, surgery, the techniques, and even just, is surgery going to help out with pain? So I think that we're going to be able to cover a lot of information here. But for the listeners who might not have heard of you before, or just introducing to you for the first time, tell us a little bit more about yourself, your background, and how did you got involved with spinal surgery?
Well, I lived on 3 continents. I'm born in Iran. After first year of my med school in Iran, it was a turmoil. It was a crazy time, for lack of other term. I went to Germany. I finished MD and PhD in Germany, University of Heidelberg. I did 3 years of residency in Germany in neurosurgery. Then I started a fellowship, in research fellowship in Stanford, California. Then I did a general surgery internship in Dartmouth College. And then I went back and started a whole new residency in Texas. And I have been board certified for the last 11 years. And it took me, the joke is that it took me 23 years after the high school to become a neurosurgeon. And I have lots of titles. Each of them, in average, each letter of those titles took me 3 years to obtain. But I just can tell that I learned a lot during that time. And I wouldn't have spent my time in any other way. In the last 10 years, I have been specializing myself in the so-called minimal invasive spine surgery. And when I talk about minimal invasive spine surgery, I know that this word, everybody has heard this word, minimal invasive spine surgery. And there are a few jokes I'm going to tell during this podcast. One of them is minimal invasive surgery is exactly what the surgeon does who's talking about it. No matter what he does, it's always going to be minimally invasive spine surgery, because there is no definition of that. Everybody calls what he does minimally invasive. But more or less, it's about causing less damage during the surgery itself. In any kind of surgery, we have to get to the place, to the structure where the problem is. And the spine is exactly in the middle of our body. No matter which angle we take, we have to go through lots of tissue there. And it's amazing that first in the last 10, 15 years, our technology is good enough to go and treat those conditions with truly minimal damage to surrounding tissue. And the methods that we have had so far always would require us to open up your belly, put your major organ at rest, or go from the back, not figuratively, literally fill you open, push all the muscle to the side. By the way, you're a doctor of physical therapy, correct? That there is a joke, right. Another joke among us spine surgeons. We take your patient, we destroy all the muscle in their back. After 5 surgeries, we send them back to you, say, go fix it. But truly, for the last the 70 years, the standard of care has been stripping all the muscle from the bone to get where the pathology is. And as a doctor of physical therapy, what happened to the muscle that you detach from the bone, you denervate, they all turn into scar. They're not muscles anymore. They are scar tissue. You cannot really use them to build up any good foundation for posture, for reflexes, for spine, and so on. But that is all we could do for a very long time. Just in the last 15 years, our knowledge that we have gained and technology is good enough to avoid that, not cause too much damage. I think another thing that we need to talk about is most of the surgeries that we do for the spine is for pain management. And this is just the fact of a good surgeon. If there is any other way to help the patient, surgery should not be considered, except two small reasons, like acute progressive deficit based on pressure on the nerve and spinal instability, which are less than 2 to 3% of the cases. Every other case should go through a rigorous process of maximizing all the other treatment to manage the pain before surgery is offered. And one of the problem in human history is that we go always from one extreme to extreme. We used to not do surgery because they were dangerous, and then we used to do a lot of surgery because we could do that. Then we do too much, and then it does too difficult to justify that. We stop doing them, and we create a lot of narcotic addicted people because we didn't manage their pain. And then every time we go back and forth, we gain more knowledge, and if we are coming now to a good center, we understand now when to do surgery, when not to do the surgery. But everybody needs to understand as well that even though we treat the pain, we want to treat the pain. People who have had spine pain, they know how it is. I have had it myself, where you cannot move an inch, where it takes you 15 minutes to get up the chair, for 15 minutes to get in and out of a car. So people who have had that, they know this is a different kind of pain. But as well, I hope everybody understands pain is a signal. Pain is not the problem. Pain is not the fire. Pain is the noise of the smoke alarm, that something is burning, and we have to pay attention to that. So in the spine, because the maximum amount of nerves are concentrated in our spinal cord right there, that smoke alarm can be very loud. And it makes us listen to it. And that is the purpose of the pain, to listen that there's a damage there. Now, there are lots of ways that how we can help the patient. By, first of all, avoiding things that cause the injury, strengthen the core body muscle, sometimes bracing, injection, and so on. But more or less, there are conditions that only surgery can really help the patient. Now, the surgeries has been traditionally very, very invasive. And sometimes that there's an old joke says, "Doctor, your cure is worse than my disease." In some cases, unfortunately, our surgery causes more damage. That is, we say spine surgery begets spine surgery, because we do cause so much damage in the first surgery that that damage propagates to the next level and next level. But I guess, considering it's 2023, our knowledge base, our experience, our technology is just coming all together, becoming mature enough to truly making a huge impact. And we just talked about that. This is a public health issue. It is hard not to know somebody with a spine problem. By the time you're 70 years old, there's only 1 to 2% chance you don't have a spine problem. Obviously, we have these tremendous protocols to help vast majority of these patients without the surgery. But when it comes to the surgery, and make no mistake, this is in Becker's spine, there was an article, 1.62 million of the spine surgeries are, this kind of spine surgery are performed in the United States annually. This is a public health issue, and our ways, how we do these surgeries, are standards which are set in 1950s with so-called posterior lumbar interbody fusion, or PLIF, and 1980s with transforaminal lumbar interbody fusion, which is called TLIF. These standards are 40 and 70 years old, and they cannot take us to the next step. So I know that this is a lot of information to process, but I'm sure in your professional life, in your surrounding, your family, you have encountered many of these facts that we talked about. What makes you interested in the spine surgery, at least what makes me interested, is that my both parents had this problem, and they truly, toward the last 5 to 10 years of their life, at that time, there was really no option. They were homebound. They couldn't do anything. And I felt what a big deal it is. It is hard to be old, but it's so much harder to be old and not being able to walk and be in pain. So that is truly a public health issue.
This episode is brought to you by the Sciatica Protocol. Experience pain relief directly through your phone, anytime, anywhere. Interested in learning more? Check us out at ifixyoursciatica.com/the-sciatica-protocol. Absolutely. I think, one, the pain that we deal with, I think what's really interesting is that if we're looking at just a general pain scale, we'll say 0 to 10, what's really interesting is that in some cases, and I know especially from like the American public standpoint, is that for the majority of the time, we can live with 2 to 3 out of 10 pain. Like that's something that we can live with. And interestingly enough, I know like dealing with a lot of the insurance companies is that if you have 3 out of 10 pain or less, you're actually discharged from physical therapy because you are considered functional. But what ends up happening is that we're dealing with this pain for a long period of time. As you said, Dr. Abbasi, the pain that we're experiencing is the smoke alarm going off, right? That smoke alarm going off tells us that we need to make a change. And oftentimes, by the time it's too late for us to, but by the time we're trying to address it, it's a little too late. The damage has been done. Before we actually started recording this podcast, you made some really amazing observations. And I think if we're looking at the concept of the car and the human body going through the typical surgical procedures, the PLIF and the TLIF, you were talking about like going through the entire car to fix one specific problem, and you come back and the patient's already beaten up. But one of the analogies that I thought you said particularly beneficial was actually say like your spinal discs, right? Because a lot of people who are experiencing sciatica pain, they're trying to figure out, is it their disc pain or is it their issues? If they have a herniated disc, what were the causes and everything? So would you be okay with sharing that herniated disc entire analogy? Because I thought that was extremely powerful to help people visualize that. Yeah.
See, our spine is made of interspersed bone and disc. That this bone and disc, that's practically what stabilize and enable us to have all the other organ and be able to move and so on. And it moves in a way that this interspersed bone and disc, first of all, each disc is a cushion between two bone. And then that's keep this bone separated. Between each of those two bones, a nerve goes out. That nerves make you move, make you feel, make you do anything you do, except your face and the head. Everything you do is based on those nerves. Almost everything you do is based on those nerves that exit between two bones. And the cushion between the disc, in a way, behaves like a tire of a car. What that means is you have a good, pressurized tire. Your rim is not on the asphalt because you cannot drive like that. But then when and like a tire, there is 3 reasons a disc become bad disc, and then you have a problem. Obviously, genetic is always part of it. It's if you have a good brand tire versus a bad tire, how you come from the factory. The second fact is even a good tire, you drive it long enough, you're going to have problem. So that's the aging process that we cannot change. And the third factor, which is as well a very important factor, is so-called how you use your tires. If you drive on sharp stones, you're going to have wear and tear much faster than if you don't drive on sharp stones. Like everybody knows, the professional athlete, their joints are 10 to 20 years older than they are because they really put them at lots of use and so on. I'm not talking about a regular sport, but I'm talking about truly overusing your joint and spine. But eventually, no matter where you are, and that statistic that comes in play, by the time you're 70 years old, there's only 1 to 2% chance you don't have a spine problem. and that is as well proven in the statistic. Spine has been always a major reason for disability. Like in 2015, spine was number 2 reason for disability in the United States, and it was number 4 globally. Now, spine is number 1 reason for disability based on a study worldwide. So these are the common problem. These are not rare issues that once in a blue moon you have a patient like that. This is your mother, your father, your grandparents. And that is truly impact our society tremendously. I get a lot of this elderly patient that open surgery is not an option for them because it's too invasive. And the family takes turn taking time off work just to make sure their loved one is taken care of. So this is truly a tremendous economic impact on our society, on our healthcare, and as a whole in the society at all.
Yeah, absolutely. And so, it's affecting a lot of people. And if we're looking at it, and I love this representation or the visualization of the car, I often tell patients when I see them post-op that the surgeons helped replace the tires, the rims, they fixed the car. And now it's my job to help them drive the car correctly. I'm their driving coach. I'm going to teach them, okay, you're going to be approaching this stop sign. Don't slam on the brakes. You have to know you're going to approach the stop sign. You got to step on those brakes slowly. So let's talk about these various different techniques. I know that with minimally invasive spine, you just described that there's multiple different areas of the spine that can be addressed. You have the bony landmarks. You also have the discs themselves. You also talked about fusions. So what are some of the most common surgeries that you do at your clinics? And what would the indications be for each one of those techniques?
Let's use that car and tire analogy, right? You can have a flat tire, you patch it. But you imagine at times the tire is not just a small hole. It's a slashed open, a knife, a samurai sword sticking out of your tire. You have 20 holes. Patching it's not an option anymore. And then you have those cases that not only you had a flat tire, you have been driving from Los Angeles to San Diego on a flat tire. By the time you are at your destination, after years of using those flat discs, practically the bone has changed and bone grown in all the wrong places. And there are lots of vital structure, nerves and so on, just very close proximity to all this structure. And for the people who never had that, I doubt that, but they want to know what the direct pressure on nerve look like. I'm sure anybody have hit his funny bone on the table. There's nothing funny about it, is it? That is how these people
Absolutely.
are all the time. That is how it feels to have direct pressure on the nerve, and that is how that pain feels. And imagine now not having this for a moment, having it constantly. These patients are suicidal. These patients gather their pills to commit suicide. And many of them, they tell me, doctor, if you cannot do anything for me, if this is all what's left, I don't want it. I understand that. But many times we surgeons, we have learned ways of surgery, and we are good at that. We weigh risk versus benefit. And we weigh that, and if in an open surgery, traditional surgery, the risks are more than the benefit for the surgery, we say, no, you cannot have the surgery. And I hate to say that for some of our colleagues as well, they do the safe thing, but they do the safe thing for their own practice rather than for the patient, because this patient stop walking, they decondition, they die because the heart gives up on them. Some of them commit suicide, not few of them. You have heard of that narcotic epidemic and lots of narcotic death and so on. There is a dark number of those. These are not overdose. These are mass suicides because these patients are in pain and nobody else is able or willing to help them. I have over 1,000 patient testimonials on my webpage, on my YouTube account, where many of these patients, they talk, I cannot do anything. I cannot be good to my family. I cannot do anything positive. I don't want to live like that. And when you see those histories, when you see those the stories and you talk to them, then you want to literally take more risk for the patient and then give them an option. Obviously, we are not cavalier about doing surgery, but I think that has been my blessing, that I reduced the risk of the surgery so much. Now, giving a 5-level fusion option to an elderly 80-year-old is a totally reasonable thing to do. And those patients are coming from entire United States to me for that, exactly that reason. They are told by 5 other surgeons there is nothing can be done for them. They have to live with the pain, and they don't accept that. Thanks God we have internet. They go and learn about their problem, and they find us and they come to us. And that's a daily occurrence.
And especially the deeper you go, the more risk it is, right? Because with surgeries, we're going to have to deal with anesthesia, oxygen, breathing, even just the aftercare, right? I remember just even reading the instructions and going through my training. It's like post fusions. If they're going posteriorly, they have to make sure they can't get that wet, right? Because we're risking leak in cerebrospinal fluid, like all those different risk factors. And so being able to have these minimally invasive procedures, it allows us to get it moving. And one of the things, so the technique that I read of yours that you were doing successfully was the OLIF. And I thought it was, and coming up to this, I was trying to do a little bit of research to just get a little bit more knowledge about the techniques and also the outcomes as well. I think one of the concerns that people say, like, okay, well, these surgeries are just short-lived. Oftentimes people are waking up just out of anesthesia and they're not in pain. It's like, well, of course they're not in pain. They're still having anesthesia in their body. And I see this also in patients who are coming out of hip and knee replacements as well. They're feeling great during days 1, 2, and 3, but then it's days 5 through 10 is actually where the worst happens because the anesthesia wears off, the swelling gets worse. And so I started thinking, okay, well, what are the 6-month, 1 year, 2 year outcomes? Because that actually helps us figure out, is it actually helpful? And it was really exciting to see that technique and the papers that you wrote actually talked more about those 6-month, 1 year, and 2 year outcomes. So could you share us a little bit more about that procedure and what are some of those indications for that?
Absolutely. We describe the method of the surgery through our anatomical approach. Like we called it posterior lumbar interbody fusion. Interbody fusion, so you see a lot of lifts, LIF, lumbar interbody fusion. And that is how we get to the disc. That's how it describes. PLIF, posterior, meaning coming from the back. Transforaminal or TLIF is coming a little to the side, not directly from the back, and bypassing the spinal cord, just going tangential to spinal cord through the disc. And then there is a so-called far lateral, meaning going a little more to the side. And there is the anterior, ALIF, coming from the front, opening up your belly, pushing the organs to the side and going there. And then there is so-called direct lateral or XLIF, extreme lateral, where you go directly from the side, but still you have to go through some organs and so on. And then there is 2 kinds of OLIF. One OLIF, you go oblique through the front, that is OLIF, and we add to that ATP anterior to psoas. Psoas is a muscle in the front that we are in the front of that muscle. And then there is, in that procedure, you still have to go through the belly. And then there is so-called OLLIF, or oblique lateral posterior lumbar interbody fusion, which is my procedure where patients on the belly, and then we go truly at an oblique angle from the back, and we are exactly at the border between the abdominal organ and the muscle of the back. And that is a very thin membrane. And just in the last 10, 15 years, we have the tools and the knowledge to navigate in that very thin, almost membrane, find a safe path to the disc, and do the surgery through a tube that is barely thicker than this pen. And that's all the advantage of the thing come from. Right? We don't have to go through the belly to open up all your organ, go through your major vessel, put them at danger. We don't have to fillet your back. We go exactly between those 2 major structures and respect them both. And that enables us to get to where the problem is without causing a lot of collateral damage. And that is why this patient, so I'm going to just give you a statistic. My patient usually walk within 2 hours after the surgery. They usually, 96% of them are discharged within 24 hours. About for 2 to 4 weeks after the surgery, vast majority of my patients are back to basic daily activity. And within 4 to 6 months, bones start growing. For traditional surgery, at least double, triple, quadruple those numbers. So most of the efficiency in medicine comes in 5 and 10% intervals. Now, all of a sudden, we have a procedure that in every category, few 100% improvement on what's already down there. But as well, the problem is truly navigating in that very thin membrane. It requires a lot of skills and instrumentation and training. Not that it's very special that any surgeon can get those experience and those skills. But, that is not, because this is new. This is not being taught in universities, and we are just gaining momentum to teach that. And that is why I took on myself, actually, I bring surgeon and I teach that. There is not a month that I don't go nationally and internationally and teach this technique. We just got invited to go to India and Saudi Arabia to teach the technique. I came back from Oman and Ecuador and Germany. I taught this procedure just this year. And so wow. I think there is our medical community is mature enough now, is ripe to embrace this. And like any other new technique, it has been a huge resistant to anything new. Medicine is the most conservative kind of thing we have. We stick to old ways, but it's now truly spreading out.
Good. And I'm glad. I mean, it's great. I mean, so as you're describing this, I'm visualizing, say like a piece of let's see, corned beef, for example. Like what's really interesting about corned beef, it's brisket. Brisket actually is 2 cuts kind of formed together. But what's really interesting is that it's considered 1 cut, but there's a thin membrane that actually separates between the 2, and you don't necessarily need to slice the meat in order for you to separate it. So I think that's really helpful, and it's exciting to hear that the less force you need to apply, the less collateral damage, as you said, the better the healing process. And I love the fact, and especially early on in this conversation, Dr. Abbasi, you talked about, one, the surgery is a tool, it's a technique, but you're going through all these different stops before you actually even consider this patient going through a surgery like that. Because even though it's minimally invasive, they're still putting themselves under the knife. And
absolutely. And
as you described, there's a lot of really good benefits, but that's only if we exhausted all those different options. And so, And I'm in such agreement with that. I'm really appreciative that you're sharing this with the world and sharing it with us, because this is a great opportunity is another opportunity for people to experience pain relief when they couldn't, especially when they've lost hope. And so we've talked about the benefits, we talked about the technique itself. Tell us a little bit about the risks, right? Because every time that we get under anesthesia or anything, there's going to be some sort of risk, just so that we can have a better understanding.
No, surgery is not the only thing we do. As a matter of fact, surgery is a small thing what we do. Now, who needs the surgery? Who can benefit from other things? That is a major thing we do. We have developed what we call a so-called inspired spine multidimensional protocol. You remember we had a joke that if you give 5 spine surgeons 1 case, you come back with 7 different opinions. And one of the tragedy of spine is that the kind of treatment you get has nothing to do with your pathology, but who you meet first. Now, we are trying to overcome this problem by protocol that is very visual. You can go to YouTube, as a matter of fact, and put Inspired Spine Multidimensional Protocol. I give a whole presentation of that. There are very few conditions that you hit the door, you get the surgery, less than 2%, where something is pushing on the nerve, and if you don't treat it, the damage will become permanent because the nerves are very delicate. But beside that, or instability, like you have an accident and your spine is just moving the wrong way. But beside that, the saying among us is, if anybody else can help the patient, we shouldn't. Even though our procedures are very little traumatic to the tissue, but still a surgery, you're absolutely right. In medicine, though, the risk-free procedure does not exist. But what we do in our studies that we have published, we have 11 of them published. In a peer review, you just have to go to PubMed or a National Institute of Health, NIH, Abbasi, OLIF, then you get all those papers. We compare it to what's the standard of care. By standard of care, it's so-called TLIF, transforaminal lumbar interbody fusion. And in our study, we compare them very clearly. Like in a transforaminal, in the standard of care, the risk of infection is 3 to 5%. In our study, the risk of infection has been 0.2%. The bleeding is 1/10 of the open surgery. The risk of nicking the dura, you remember you talked about the CSF leak and the cerebrospinal fluid leaking out. That risk in the open surgery in TLIF is about 8.7%. In our 1,500 case study, not a single CSF leak has been observed. Then there's the nerve irritation route, nerve root irritation or nerve irritation. Everybody hush in the literature, the early result, they go to 1 year result. That 1 year result varies significantly, but in average is considered 1 to 3%, in some studies 5%. In our study, in 303 patients, only 1 patient had damage from the surgery itself. That makes it 0.3%. Some other people had non-life limiting, no deficit, like some numbness and so on. But so comparing it to the traditional surgery, the improvement is not 10-15%. Is by a multitude, like 1/10 of the blood loss. Like open surgery has 1,000% more blood loss. Open surgery has 15 times more risk of infection, and so on and so forth. But all of those are truly published, and it's when you come to the core of it, it becomes very trivial. You cause so little damage, so your body has to recover from less damage to the tissue, and so you recover faster and better. I mean, that's all actually very trivial, all what's to it.
It's really helpful. And I'm so glad that you're able to share the comparisons because the more trauma people experience, the higher at risk it is. And so Dr. Abbasi, it's such a privilege to have someone like of your caliber to have really kind of spearheaded this new approach and going around the world and teaching other physicians about it, and also really using that multidisciplinary approach to make it so that if someone else can fix it, let them do it before they have to actually even go over the knife. And I love that. And so you're teaching these physicians, surgeons all across the world. And what's really cool is that the listeners here are living all across the world as well. So if someone is at their wit's end, they've tried everything and they said, okay, I want to see you, even if these opportunities and seeing the teachings, people under your teachings, what is the best way for the listeners to either get in touch with you or get more information about how to access the care that you and your clinics provide?
It's just Google Inspired Spine. That is all you need to do, and it gets you there. Now, there is a reason we call this Inspired Spine. It comes back to a quote from Max Planck. Max Planck is the father of quantum physics. The reason you and we can talk on a computer is because they have built these chips understanding very tenet of the quantum physics, how electrons work, how they interact, so when he came with this revolutionary idea, people laughed at him. They didn't take him seriously. Many years later, what he did was not a matter of laughing anymore, and it was widely accepted, and he won the Abbasi Nobel Prize for that. He sort of summarized why he was successful. He said the big moments in the human history, in the science, he was referring to science, they don't come from big universities or big names and so on. They come from inspired, that's the word he used, they come from inspired individuals who dare to go in the front of the status quo and find a different way. Think outside of the box. And there is another very cynic quote from him, because he was denied by lots of his contemporaries. And he said, science improves one funeral at a time, because those people who don't deny that improvement and so on. And I want to emphasize that here, that for the first 7 years when I was doing this, it was a lonely fight. But now it's really gaining acceptance. But that's not unusual in medicine. There's a story I want to share for everybody listening to that. Go read about Barry Marshall. Is that name, it says anything to you?
Rings a bell, but tell me more.
So Barry Marshall won a Nobel Prize for his persistence. He was an Australian doctor who discovered something very special. See, in 1950s, 60s, and 70s, there was a disease that we barely hear about it anymore. It was used to call gastric or duodenal ulcer. You would have a hole in your stomach and you would bleed and you would die. The solution for that would cutting you open, and cutting your stomach out, the part of the stomach that was bleeding, cutting it out. There were hospitals that were just specialized in that. In some estimate, about 1/10 of the patients from those surgeries died. Morbidity, mortality up to the roof, but that was the only thing we could do. He found out in the stomach of many of those people who have that, there is a bacteria that is like a corkscrew. And for that reason, it was called Helicobacter pylori, because Helicobacter, meaning that it's like a corkscrew, and pylori, because it was in pylorus, meaning in the part of the stomach, it was isolated from there. And he was wondering if that has anything to do with his ulcers. And he, lo and behold, he found out that that can actually be the reason, not can, but that is the reason why these people's stomach become weak, then the acid eats through the flesh and they bleed and die. He said, this is a gastric ulcer, is a bacterial disease. Let's treat it with antibiotic. I hate to say what medical community did to him. They literally laughed him off the stage. Do you know what he had to do to get accepted? He had to infect himself with Helicobacter pylori, get a gastric ulcer, then treat himself with antibiotic, and then prove, but he's persistent.
Yeah.
Paid off. He got a Nobel Prize. But do you know how long it took for his knowledge to get acceptance?
30 years.
Yes.
Whoa. Yeah.
28 years.
Oh my gosh.
Do you know
oh my gosh.
Do you know how many people died of those procedures in that 28 years?
I mean, if you're looking at 1 in 10, right? And they're probably doing, we'll say
home surgeries.
Right? So we're probably looking at, we'll say conservative. Yeah, hundreds of thousands, right? Wow. And so be able to look at a problem and say, why can't we create a solution to this?
Yeah.
I think that's important. And I think one of the challenges in medicine in general, even in the physical therapy world, is that we leave our school and we kind of put these blinders on saying, like, this is going to be our wheelhouse. Like, we've always treated that way. And I think one of the
most dangerous thing in life.
Yeah.
You always have done it that way.
We've always had done it. Exactly. And so I really appreciate, Dr. Abbasi, being able to, in a way, in the most positive way, challenge the infrastructure and what has been done, but going it at a way of, and I really appreciate your attitude of going into this, because a lot of people, when it comes to initiating change, they're thinking, okay, we're going to disrupt the market. Like, we're doing this because we're so tired of X, Y, and Z. But you came into it saying, why can't we do this with less trauma for our patients, and being able to go through that and finding those membranes that allow us to be able to address these issues with the least collateral damage as possible. And I think that's extremely powerful, and it is great. And I really appreciate your time, Dr. Abbasi. Your knowledge is amazing, and I'm so excited for the listeners to hear about this, to see what options are there in the event that they've gone through various different modalities and they're thinking, okay, well, I might need to go under the knife, but why not go through the minimally invasive opportunity first, and try that out, especially with the multimodal approach, the protocol that you're recommending. So thank you again.
Well, thank you so much for having me. And you may know, we have our own podcast, which is called Essence of Medicine. I'd like to invite you to our podcast and enjoy from your knowledge in your physical therapy. So I'm officially inviting you to come to one of our podcasts and share your knowledge with the.
Oh my goodness.
That would be a fantastic. I would absolutely would enjoy that if you could as well continue with me this campaign of educating our patients.
Absolutely, Dr. Abbasi. It would be an honor. So thank you.
Thank you very much. Well, it has been my pleasure, absolute pleasure to be with you.
Thank you so much for tuning in. We hope you got some help from today's podcast. And for more info, check us out at ifixyoursciatica.com. Have a fantastic and pain-free day. No patient-therapist relationship is formed by listening to this podcast. We are not providing medical advice, and all information should be confirmed by a medical provider.